Hello everyone, it's 5 o'clock, so we will kick off. This webinar is the first to be hosted by Medela UK, and we're really delighted that so many of you have joined us to look at this really important topic. So starting things right, fostering successful lactation practices for at-risk women and their babies. For those of you that don't know me, I'm Helen Pallett. I'm the educator for Medela UK, and I'm thrilled to be joined today by my colleague Heather Scott, and she will be presenting the webinar. Heather is a midwife and she works in our global education team. This webinar forms part of our Science into Care ethos. As you probably know, Medela has a strong history of investing in basic and exploratory research with global key opinion leaders. And these webinars are a great platform to share key findings and best practice. Before I pass over to Heather, just some housekeeping. We welcome your questions, and please could you type those in the questions box on your control panel, and we'll answer a few of those at the end of the session. Hopefully you've already managed to have a look in the handout section. Here you'll find lots of information that you can download. We have the infographic to support the webinar, talking about risk factors. We have some information on our new breast pump that's coming to market, our new hands-free breast pump. So it'd be great if you could take a look at that. There's also some information in there about a new service we're going to be offering called Medela University, which has online education for breastfeeding and lactation. And most importantly, this is where you'll be able to download your attendance certificate as well. So finally, at the end of the webinar, a short survey will pop up on your screen, and we would really appreciate your feedback. With this being the first webinar, we'd like to take all your comments on board. Right, that's everything from me, so I will pass over to Heather. If you just bear with us, we've got a few clicks.
Thanks, Helen. I will just
share
my screen. Can you see my screen now?
Yeah, just need to go into presenter mode. That's it. I'll come off camera now then. Over to you. Thanks a lot.
Thanks, Helen. So, hello, my name's Heather. Oh, hang on, sorry, I've just lost my slides. There we go. Sorry, a technical issue. My slides keep disappearing. Here we go. Okay. Hello, my name's Heather. I am a UK registered midwife, and I welcome you this evening to the presentation, Starting Things Right, Fostering Successful Lactation Practices for At-Risk Women and Infants. So let's have a look at the learning objectives. By the end of this presentation, we would like to firstly have an understanding of secretory activation, previously known as lectogenesis 2, an awareness of what delayed onset of lactation is and its potential effects on lactation, identification of women at an increased risk for early breastfeeding problems, an overview of the hormonal, physiological and emotional differences between labour and birth outcomes, a comprehension of how different types of birth can affect lactation in the first few days, a recognition of how certain risk factors impact the type of labour, birth and first breastfeeding experience a woman has, an understanding of how certain labour and birth outcomes negatively impact breastfeeding, and finally, to have knowledge of evidence-based best practices to ensure effective milk supply and breastfeeding. So we can now look more closely at the stages of lactation and the dramatic hormonal changes that are happening at the critical time point of birth. This will highlight why the first few hours and days after birth are a time to act with a sense of urgency. The graphic shows the milk production journey in terms of daily volumes, which are of course low in the first few days and increase dramatically once milk has come in, otherwise known as secretory activation. Then between 2 weeks and 1 month, daily milk volume stabilise to the needs of the infant. This is established lactation. Progesterone is the first key hormone to mention here, It's been produced by the placenta during pregnancy and has been supporting breast development or secretory differentiation. Progesterone is a prolactin inhibitor and therefore prevents substantial milk production from occurring during pregnancy. Once the placenta has been delivered, however, progesterone levels fall, which triggers secretory activation or milk coming in. The next key hormone to mention is prolactin. Prolactin is required for secretory activation and building milk supply, which supports the closure of the lactocyte tight junctions. We'll see this in the next slide. Once progesterone levels fall, prolactin is free to promote secretory activation or the switching on of milk-making cells. Each suckling event induces a prolactin surge to signal the production of milk. Prolactin levels and suckling-induced surges decrease over time as milk supply is established, indicating a critical window of opportunity. Another key hormone, oxytocin, is responsible for stimulating contractions during labour and remains high in the first few days after birth. Oxytocin pulses occur during suckling and are required for the release of available milk through lactation. If we highlight these early days and hours after birth, it's clear that with all of the dramatic hormonal changes occurring, and these are just a few of some of the relevant hormones involved, that this critical window is here to initiate milk supply. The responsiveness of the breast in this window is heightened, and timely and appropriate intervention in this time has a lasting effect on long-term milk production. Now let's have a look at what's happening down at a cellular level. This is an illustration of a bunch of alveoli in the breast tissue made up of lots of lactocytes or milk-making cells. They're covered in a network of capillaries that supply the alveoli with blood. In this cross-section diagram, we see the center of the alveolus called the lumen. Just get my little pointer. So this is the lumen. The components which make up the milk are secreted into this space, and the milk itself is gathered here. If we now concentrate on one lactocyte and zoom into the picture, we end up with an image like this. The top part is the alveoli lumen, where milk is stored, and the bottom represents the capillaries covering the alveolus on the outside. So what happens when milk comes in? Due to the hormonal changes mentioned before, key events will be taking place in the lactocytes or milk-making cells. These events occur as the breast transitions from its pregnancy state to activating the ability to produce large volumes of milk, which is called secretory activation. Initially, when the baby's born, there are gaps between the lactocytes in the breast, so here. Before the closure of these spaces between the cells, large volumes of milk cannot be made or maintained in the lumen of the alveoli. A key reason for this is that lactose, the breast milk sugar synthesized in the lactocytes, can move freely between the alveoli lumen and the blood flow between these spaces. During the early stage of lactation, these spaces begin to close, driven by the fall in the hormone progesterone, which allows the hormone prolactin to function. Once spaces are closed by tight junctions, the cells are connected to each other, which helps communication between the cells and regulates the composition of the milk. When the spaces between the cells are closed, lactose cannot move freely between the alveoli lumen and the blood flow, and so milk accumulates inside the lumen. Here. The lactose in the lumen functions as an osmotic regulator, attracting water into the lumen, so that large volumes of milk can be produced. These are the cellular events that occur at the first hours and days after birth and underpin the transition from the small volumes of colostrum to copious milk volumes. This transition is known as milk coming in, or secretory activation, previously known as lactogenesis 2, and should take place around 72 hours post-birth. Early and frequent breast stimulation in these early days is essential to optimize this process in order to support timely milk coming in and long-term milk production. Now let's take a look at when secretory activation normally occurs and how this is noted in the mother's breast. Most women who've experienced a physiological birth will experience secretory activation up to 72 hours after birth. Women often describe the feeling of fullness or swelling in the breast and may also report leaking. Secretory activation occurring within the first 72 hours is a positive indicator for ongoing lactation outcomes. In order to better understand how optimum milk removal and how to optimize milk removal and support mothers to come to volume, let us look at the physiology of milk production. Once milk has come in, milk production happens by a process of supply and demand. The more milk that is demanded or removed from the breast, the more milk is supplied or produced. First, we'll look at the demand component. Whether a mother is breastfeeding or pumping, suction is applied to the breast. In general, faster suck frequencies function to stimulate the breast and trigger milk flow, while slower suck frequencies function to remove the milk once it's flowing. Fast suck frequencies of the baby or pump trigger the release of the hormone oxytocin. Oxytocin ejects milk from the breast. This is also known as the milk ejection reflex or letdown. Mothers can have 4 to 5 milk ejections over around 15 minutes, but this will of course vary between mothers. Each milk ejection is a window of time when milk can be removed from the breast, and these windows last for around 4 to 5 minutes each. 4 to 5 minutes each. I have a strip of buttons over my notes, which is not helping me, but never mind. Since milk ejection is required for effective milk removal, it's very important for mothers who need to pump that they use best pumping practices that support effective milk removal during these windows. These practices include double pumping, adjusting vacuum to the maximum comfort level, and using correctly sized breast shields. Each time milk is removed from the breast with suction, the suckling-induced prolactin surge that signals the production of milk occurs. This surge takes place around 45 minutes after milk removal. Frequent feeding or pumping trigger frequent prolactin surges to increase milk production. This is particularly important in the first weeks after birth, since this practice takes advantage of the fact that the baseline levels of prolactin are higher too in this critical window. It's also important for us to talk here about the significance of on-time secretory activation. Much of the literature talks about delayed onset of lactation. Milk coming in after 72 hours postpartum is considered delayed, and delayed onset of lactation is defined as little or no maternal perception of breast fullness or leaking from the breast after 72 hours from birth. Throughout the literature, we see that the occurrence of delayed onset of lactation is anywhere from 17 to 44%. But why is this important? Delayed onset of lactation has been shown to lead to excessive infant weight loss and an increased need for formula supplementation, as well as shortened duration of breastfeeding. Women who experience milk coming in after 72 hours have a 60% higher odds of stopping breastfeeding at just 4 weeks down the line. This factor is highly significant for us to consider. Therefore, timely interventions to avoid a delay in secretory activation is critical. Research has shown us that there are some conditions or circumstances which put mothers at a greater risk for delayed onset of lactation, which we'll see on the coming slides. So let's first look at the risk factors for delayed onset of lactation. Many of these risk factors can actually be assessed and noted during pregnancy. So for example, primary parity, maternal age over 30, diabetes, maternal obesity, breast reduction surgery, planned caesarean section, and induction of labour. It's important to be aware of induction of labour because compared to women who have spontaneous labour, those women who have an induction are more likely to have a caesarean section, epidural, episiotomy, and PPH, which leads us into our next slide where we can discuss the risk factors assessed during or after birth. So there are risk factors that we identified that can be noted during pregnancy or before labour, but there are also risk factors that can occur during labour or birth, or even in the postpartum period, which can impact a new mother's natural lactation processes. These risk factors include an unplanned or emergency section, psychosocial stress and/or pain, stressful or prolonged labour, a postpartum hemorrhage, preterm birth, mother-infant separation and missing out on those vital prolonged skin-to-skin contact after birth, a delayed first breastfeeding episode or feeding less than 8 times in 24 hours, and formula supplementation within the first 48 hours. Over the next few slides, we'll discuss both physiological, labour and birth and compare this to induction and medicalised birth practices so that we can have a greater understanding of why an infant exposed to these risk factors is more likely to have breastfeeding difficulties in the first hours and days, as well as how these risk factors can lead to physiological delay in the onset of lactation. Current understanding is still unsure of how labour starts, but it's believed that the infant sends a hormonal signal to the mother to start labour. In response, the mother's oxytocin levels rise slightly, and the oxytocin receptors in the uterine muscle become more sensitive. This combination makes contractions stronger and more noticeable. Beta endorphins are the body's natural opiates, and they begin to rise in early labour to provide pain relief. If there's too much adrenaline, oxytocin is suppressed and contractions may stop. Early labour can last many hours and sometimes days. This facilitates a steady buildup of beta endorphins, which assist with pain relief and in established labour. In established labour, contractions become stronger and more painful and powerful and do not slow down in response to mild stress. Cortisol and beta endorphin is increased to a very high level to relieve pain and reduce stress. As the mother births her baby, oxytocin and beta endorphin levels rise further, along with prolactin. When the baby is placed in immediate skin-to-skin contact after birth, stimulation of the nipples and kicks against the mother's abdomen help to stimulate contractions and assist with delivery of the placenta. Rates of induction of labour are rising globally, and around 1 in 3 women's labours are now induced in some high-income countries. In the USA, 31.4% of births were induced in 2020, with a similar rate seen in the UK. Now let's have a look at what an induction of labour entails and how it differs from physiological birth. The first part is to open the cervix slightly by using medical interventions that enable the amniotic sac to be broken. The second part is to create contractions with medication. Those early latent phase contractions which help prepare the mother and baby do not occur in induction of labour. The contractions are created using a synthetic version of the oxytocin hormone via IV drip. Strong contractions usually occur within a couple of hours of the drip starting. This does not allow time for the woman's body to slowly and steadily raise the beta endorphin levels to adequately relieve pain. In addition, the brain is also not releasing oxytocin to help create that sense of calm. Contractions are kept at a strong and steady rate, and they do not alter or provide periods of rest or reduced intensity like in spontaneous labour. So not surprisingly, women of induction of labour have an increased chance of requiring pain relief. Many of the risk factors which can be identified during a woman's pregnancy are often linked with the woman having an increased chance of being advised to have an induction. For example, women with diabetes are likely to be advised to have their labour induced earlier than 40 weeks of completed pregnancy. In the case of primary parity, most first-time mothers tend not to give birth on or before their due date, but more commonly their pregnancy continues to 41 or 42 weeks. And many countries now often recommend that women have an induction of labour at 41 weeks rather than waiting for 42 weeks, as was only done a decade or so ago, therefore putting first-time mothers at a higher risk of induction of labour. Inductions of labour are increasing worldwide. Professor Darlan and her team investigated almost 500,000 births in Australia over a 16-year population-based linked study. The study found that compared to those women who went into labour spontaneously, those who were induced were more likely to have an epidural, an episiotomy, vacuum or forceps delivery, or a caesarean section. All of these procedures lead to the new mother and infant having had a more stressful labour, which we've seen is a potential risk factor for poorer lactation outcomes. Induction of labour and medicalised birth leads to an increased chance of failure to breastfeed well or at all in the first days, postpartum hemorrhage, stress, more pain post-birth, and mother-infant separation. The medicalisation of labour or birth is when any medical process which would not happen physiologically is introduced. If we follow this road, we can see how the medicalisation of labour can lead to a cascade of events. The labouring woman is assessed as having slow labour, often leading to augmentation using IV syntocinon. We know from the literature on women's experiences that augmentation and the use of synthetic oxytocin does not allow the physiological slow build-up of the contractions and the body's natural response to pain. Women, therefore, often experience much more painful labour and understandably require stronger pain relief, such as opiates or even epidural. When a woman chooses to have an epidural, this goes hand in hand with the requirement to commence continuous fetal monitoring and IV fluids, both of which restrict the woman's movement for the rest of her labour, as she's tied up to monitors and drip bags. Restricting the woman's movement in labour can lead to poor positioning of the fetal head on the cervix, which can in turn lead to a delay or lack of dilatation of the cervix and/or an inability for the infant to get into an appropriate position for birth. When this is the case, it's clear to see how labour and birth can end up requiring assistance or even a section. So why does medicalised birth impact breastfeeding? So this is now probably quite easy for us all to see. A greater need for pain medication, likely opiates or epidural, increases the risk of the infant being sleepy, ineffectively feeding, or showing good rooting behaviours at the breast for up to the first 2 days. Delayed and inefficient feeding leads to increased chances of abnormal weight loss, and this in turn leads to increased chances of the infant requiring supplementary feeds. Caesarean section brings the effects of spinal epidural anaesthesia and leads to an increased risk of the baby being sleepy in the first few hours or days, resulting in delayed or ineffective feeds, so not transferring milk or providing enough stimulation to the breast to increase the prolactin hormonal surges required to activate the milk-making cells. We also need to factor in that these mothers will have some difficulty in moving around easily in the first few days after major abdominal surgery, which can make it difficult to feed her baby. All medicalised birth increases the risk that the baby will require resuscitation at birth too. This means that the baby is more likely to be removed from the mother in the important first hour after birth and therefore misses out on the opportunity of early skin-to-skin and an early first breastfeed. If a mother has a postpartum hemorrhage, then the baby needs to be removed from the mother until she's stable, often disturbing the infant's natural reflexes to have the initial early breastfeed. And if a mother has lost a large volume of blood, this can impact her ability to move around and feed her baby in the first few days, as she'll likely be feeling exhausted and unwell. She may also need admitting to ICU, providing separation from her baby. Medicalised birth increases the risk that the mother will require an episiotomy or have perineal damage. This means that the baby is more likely to be removed from the mother in the first important hour after birth until the perineum is sutured, and therefore this increases the chance of delays in the opportunity to first breastfeed. New mothers will also experience pain over several days, if not weeks for some, which can impact on how she can sit and position herself to breastfeed. Mothers who experience birth complications breastfeed for a significantly shorter duration than those who do not, specifically those women who need caesarean deliveries or those who require augmentation for failure to progress, or induction of labour, and women who have postpartum hemorrhage. It's understandable that these women are more likely to discontinue breastfeeding for reasons of pain and difficulty if not provided with appropriate support and care. When new mothers experience difficult, long and stressful births, it can be an overwhelming and even traumatic experience for some, Add to this exhaustion, blood loss, pain, emotional upset, especially if she needs to be separated from her infant. These already start her lactation journey with potential risk factors for the delay of lactation when her milk, for the delay of when her milk comes in. In addition to this, as discussed, medicalized birth or difficult birth often leads to sleepy babies or babies who are not able to effectively breastfeed yet. This means that breasts often have reduced or no stimulation. This reduces prolactin hormonal surges, which are needed to help switch on and activate the milk-making cells. So it's easy to see why delayed onset of lactation can occur for these mothers. This, in turn, can lead to the mother not coming to volume in the first 14 days after birth, which leaves her at an increased risk of not achieving a full milk supply in the future. So now we've looked more deeply into how labour and birth can affect lactation. Let's take a look at the other risk factors to be alerted to and their influences. So mothers with diabetes are more likely to give birth to infants who experience hypoglycemia or low blood sugar. Hypoglycemia increases the chance of infants being sleepy and not able to feed effectively. If the infant's blood sugar is low, management techniques will need to be put in place, like top-up feeds with the mother's express breast milk if she has enough, or it could be artificial formula. Many hospitals now use glucose gel to avoid giving formula unnecessarily. However, if the blood glucose reaches a certain level, an infant may require admission to NICU for an infusion of glucose, which could mean a separation of mother and baby. We also see in some literature that women who have diabetes have an increased risk of delayed lactation. Resistance to insulin may impact the functionality of the hormones which are required for the onset of lactation. Insulin resistance may delay the time it takes to reach the prolactin concentration ready for the onset of mature milk production. Emerging evidence suggests that insulin is necessary for secretory activation and mature milk production. However, more research is needed in this area. In the meantime, though, what we can at least do is ensure that all of these mothers receive the best practice for adequate stimulation of the breast if the baby is unable to breastfeed effectively or at all. Obesity is also known to increase insulin resistance. Women who were overweight and obese pre-pregnancy have been noted to have a decreased response in prolactin to the infant suckling in the first week postpartum. However, the literature also reports that unfortunately, women with a BMI over 30 are less likely to receive good breastfeeding support and are less likely to initiate breastfeeding to start with. This is a complex topic to unpick. However, enabling these women to have prolonged and frequent skin-to-skin contact with their infants and providing them with supportive lactation practices could help them support women to have a positive breastfeeding experience longer term. Breast surgery may also impact lactation. There are several different types of breast surgery, the most impactful being breast reduction. The literature describes three main breast reduction techniques, ranging from minimum disruption to the areola and nipple, allowing for potentially full breastfeeding capability, to the complete removal and replacement of the areola and nipple, resulting in no possibility to breastfeed. Cosmetic breast augmentation, or implants, is one of the most common plastic surgery procedures, and the literature reports that women with breast implants are less likely to exclusively breastfeed. This surgery can cause damage to ducts, glandular tissue, or innervation of the breast. The implants may also place pressure on the breast tissue, which can block ducts, but the research is not yet certain as to whether this is the reason for less chance of exclusive breastfeeding, or whether it's more likely due to psychosocial reasons. Now let's have a look at why a mother on the postnatal ward might need to use a pump straight after birth. So for any mother whose infant does not have a first breastfeed within the first hour of birth, or is sleepy or ineffectively or infrequently breastfeeding, or is unable to breastfeed at all, of course. The mothers of these infants should be given support and advice to stimulate the breasts with pumping to replace an absent or ineffective feed, ideally 8 or more times in 24 hours, and until the infant is breastfeeding effectively and frequently. Mothers can be assisted to use pumping technologies specifically designed for the early colostrum phase until she's expressing enough milk or has signs of breast fullness. After which, if the baby hasn't yet taken over, the mother is then ready to move on to a normal maintenance pumping program. As we've already stated, the first hour after birth is a critical time for priming the breast tissue. Early breastfeeding should commence within an hour of birth. If an infant cannot breastfeed, then pumping should commence within 3 hours of birth. After the delivery of the placenta and over the following days, there is a drop in progesterone and estrogen, an increase in oxytocin and prolactin, and the lactocytes, or the milk-making cells, are switched on. Stimulating the breast effectively and frequently in the initial 72 hours after birth and prior to secretory activation, or milk coming in, is critical for future successful breastfeeding and milk volumes. Mothers who breastfeed 2 hourly experience secretory activation earlier than those feeding 4 hourly, and mothers feeding 2 hourly also have a significant reduction in the need for complementary feeding. So how often should mothers be pumping if the infant is unable to breastfeed? If the infant is unable to breastfeed at all, the mother needs to commence pumping, and she needs to pump a minimum of 8 times in 24 hours with a gap no longer than 5 hours at night. This is most likely to be a preterm infant that needs to go straight to NICU. The mother will need to pump frequently until her baby is able to breastfeed. So how often to pump when the infant is partially breastfeeding? So if the infant is not breastfeeding effectively or breastfeeding less than 8 times in 24 hours, the mother needs to pump whenever a breastfeed is missed or considered ineffective. For a healthy but sleepy baby, the mother will need to replace the missed or ineffective breastfeeds. For example, maybe the baby is only waking and breastfeeding effectively every 6 hours. This would mean that the mother would need to pump an extra 2 to 4 times during that 24-hour period. Remember, the pumping is replacing the infant when the infant is unable to effectively do it for themselves. Of course, in these situations, a one-size-fits-all approach will not fit all mothers. So what else assists breastfeeding and boosts milk supply? If the infant is not breastfeeding effectively or is breastfeeding less than 8 times in 24 hours, mothers and babies need prolonged and frequent skin-to-skin contact. This assists the infant to increase oxytocin and prolactin response in the mother. It assists the infant with its natural innate reflexes to find the breast and suckle, and it also increases the mother's confidence. Therefore, we should ask the question, should every mother with risk factors be additionally pumping alongside breastfeeding? And the answer is no. Not all mothers with risk factors will need to pump. Mothers whose infants are breastfeeding well or 8 or more times in 24 hours do not need to be pumping in addition to breastfeeding, despite any risk factors that they might have. There are no current guidelines stating that women who have risk factors but whose infants are feeding effectively should be expressing their milk in addition to breastfeeding. Mothers who are breastfeeding well need to focus on establishing good breastfeeding techniques and getting as much rest as they can in between feeds. So we have a couple of example scenarios to go through here. Firstly, we have a 35-year-old primate. She's been diagnosed with gestational diabetes in pregnancy. She had an induction at 38 weeks and she had a long, difficult labour with an epidural, and the birth was a forceps delivery in the end with an episiotomy. The baby had an initial 20 minutes of skin-to-skin contact after birth, but had to be removed from his mother while she was sutured. He was wrapped and given to a partner to hold. The baby was not interested in breastfeeding once given back to the mum 30 minutes later, still wrapped up in his blanket. They were taken to the postnatal ward and the baby in his cot was separated from his mother, who was sleeping. Now the baby is 7 hours old and the mum asked her midwife if her baby should be feeding yet. The midwife helps them to be placed in skin-to-skin contact, and after an hour and a half in skin-to-skin, He hasn't woken up or rooted for the breast yet. So what did the midwife do? She assisted the mother to double pump with a hospital-grade breast pump using pumping technology specifically designed for the early colostrum phase. She advised frequent and prolonged skin-to-skin contact, and until her baby was waking and breastfeeding effectively, she advised the mother to pump 8 or more times in 24 hours, ensuring at least one session during the night. She explained to the mother that pumping is helping to stimulate her milk-making cells, to bring in her milk on time, and until her baby can breastfeed frequently and effectively. She explained to the mother that once the baby is breastfeeding well, she no longer needs to pump. So in our second scenario, we have another primate. She's 37 years old, and she's given birth to twins via planned cesarean section at 36 and 5. The babies had an initial breastfeed and then slept for 8 hours. Since then, both babies have breastfed. They've breastfed 8 times in the following 24 hours, which sounds okay, but each breastfeed only lasted for around 2 to 5 minutes, and both babies were very sleepy when at the breast, needing lots of stimulation from their mum to keep them awake and suckling. So what did the midwife do in this scenario? After each breastfeed, she assisted the mother to double pump with a hospital-grade pump. She advised frequent and prolonged skin-to-skin contact to enhance the baby's natural rooting behaviour and feeding reflexes. She explained to the mother that the babies are not giving her milk-making cells enough stimulation, and until they're breastfeeding effectively and gaining weight well, she should express in addition to breastfeeding. She explained and reassured to the mother that she may need to pump for a few days or weeks, dependent on the individual situation. She explained that the aim was to help make sure she made enough milk and then to stop pumping and just breastfeed her babies once they were ready to take over. And importantly, she arranged follow-up breastfeeding support for this lady. So in summary, you have learnt, or should have learnt, what risk factors may cause mothers and infants to have breastfeeding and lactational difficulties in the first few days. It's always about giving the breast the correct stimulation they need. If the infant is unable to breastfeed well or at all, regardless of any risk factors, mothers with identifiable risk factors do not have to pump in addition to breastfeeding if the baby's feeding well. Risk factors are an important alert as many women will be affected by these. Identification of risk factors highlights the need for extra breastfeeding support and lactation support. There are currently no guidelines stating that mothers with identifiable risk factors must pump in addition to breastfeeding. Additional pumping should only be commenced if the baby is unable to breastfeed frequently or effectively, or not able to breastfeed yet. And that brings us to the end of our presentation. Thank you very much for listening. I hope you enjoyed it. And I will pass back to Helen, who has hopefully picked up any questions that may have come up. Thank you very much.
Heather, thank you so much. Thank you. And I've been looking at the questions and I've got a few here. The first one is around early expression. So in the presentation, you talk about getting in early with a pump. So this question says, in our hospital, we would actually get mums to hand express first for about the first 24 hours. And we do this so we don't waste any colostrum in the pump kit, small amounts of colostrum. You mentioned that we should be pumping within 3 hours. What is the best practice for these mums?
Okay. Yeah, that's a really important question. Thank you very much, whoever asked that. So it's really important, especially in babies that are in the NICU, so the pump-dependent mums, that hand expression on their own should not be used routinely during this critical window. This is not just for the pump-dependent mums, but also for those babies who are in that grey area in between. During this critical window, it's really important that we also use vacuum. So hand expression can be useful to get out the sticky colostrum, but alone it should it should not be used alone in this time period. It should also be combined with pumping. And that is because of prolactin. So I mentioned it a few times during that presentation. But if you think about the infants as the gold standard and how they breastfeed, they primarily use suction to remove milk, which we know releases prolactin and oxytocin in the mother. The breast pump also uses suction, whereas hand expression only uses compression to remove milk. Suction has been the part that shows, well, it's been shown that that is what effectively releases prolactin in the mother, which again, it does all of these really important things. So prolactin is breast programming, so it catalyzes the closure of those tight junctions that we mentioned. It prevents the death of the milk-making cells, and it upregulates the genes to make more milk-producing cells. So suction is the best answer to simulate that, and prolactin, the prolactin response sets up the breast programming. There's two randomized controls trials by Slusher and Lucia, and they both compare hand expression only to pumping only in mothers of very low birth weight infants that are exclusively having to use either hand expression or pumping. So it shows us very clearly that in these situations, that when we're only using pumping or hand expression, that hand expression yields significantly less milk volume than pumping. There are, however, studies to show that hand expression and breast massage as an adjunct method to pumping can be beneficial. So there's the Morton study, which shows that hands-on pumping, hand expression in combination with pumping, double electric pumping, can actually produce more milk volume. Yeah, so hopefully that answers your question. I think the main important part here is that critical time period, we also need the vacuum to produce that prolactin response.
Yeah, fab. When I get that question, if I'm out and about in a hospital, I always say as well, they work really well together as a package, don't they? The hand expression's amazing for getting off, like we said, those sticky drops of colostrum, but we really need to add in vacuum as well for that prolactin response. So yeah, cool. Thank you for answering that. Another question we've had is again about pumping early. Someone's commented that they don't have pumps specifically on their labour ward in their delivery suite. So is that something that you think is necessary? They've asked. I'm guessing from your presentation the answer is yes.
Yeah, I mean, yeah, that's a really important question. In short, yes. So if you think about healthy term babies, we always aim for that first hour in skin to skin with the first breastfeed usually happening within this period. So it's just about providing the same opportunity and the same sense of urgency for mothers who may be separated from their infants for whatever reason. So you might have, yes, of course, you've got those planned admissions to NICU, where it would be ideal if you had a pump available for those women straight away. But even in those situations where baby might just need to be taken for a few inflation breaths, but then actually ends up being admitted to NICU, and the minutes and the hours just pass by so quickly in those situations, and having a pump on hand in that situation would be brilliant, to have the pumps in delivery suite or on the birth suites, rather than having to wait, I don't know, 3, 4, 5, 6 hours to go down to the ward or to go and visit NICU. Once that time has passed, you're losing those critical minutes in those critical windows. So it would be amazing if we could have pumps in birthing areas, because then all mothers are provided with the same opportunity as if a baby was able to feed as well.
Yeah, it's all about that critical window, isn't it? Yeah, we've actually got a program running at the moment in the UK, delivery suite campaign. So if anyone was interested in looking at that, just contact your local salesperson, because there's some information around education on early expressing that we can provide. So yeah, we've got that as well. And then finally, the final question is around antenatal harvesting of colostrum. So what is your opinion on antenatal harvesting of colostrum? Is there any evidence that this helps with supply?
Okay, So two separate questions there. So antenatal harvesting of colostrum, we have the DAME trial, which says that for mothers who are diabetic, antenatal expression in pregnancy from 36 weeks with no other complications, that it's safe to do antenatal expression. And learning that skill of hand expression is really useful there actually as well. Getting mothers used to their breasts and used to the physiology of how their breasts lactate is really useful. The goal with the DAME trial and other antenatal research, hand expression research, was not actually to help with long-term milk supply though, so just answering the second half of your question.
Okay.
It's not really been looked at, but we know that the importance of vacuum stimulation once the placenta has been delivered and i.e. progesterone levels have dropped and prolactin raises. We know that the importance of this, and hand expression doesn't produce the prolactin response, and also when done antenatally it's in the presence of progesterone, so we wouldn't expect it to have an effect on long-term milk supply.
Okay.
But the key message would just be that yes, even if you do have those stores of EBM that you might have expressed antenatally, to not forget the importance of stimulation in the critical window.
Okay, we've actually got two webinars coming up by the global team on that very topic. So take a look on our website under webinars where you would have registered for this one. And there's one coming up on the 5th of December by Professor Diane Spatz, and there's another one in January on the 25th of January, both on the topic of harvesting of colostrum. So if you're interested in that, we've got a couple more webinars coming up. Okay, so that's all the questions, Heather. So it just leaves me to say thank you very much for presenting for us today, and thank everyone online for joining. Please fill out the survey at the end, and we will also share the link to the recording of the webinar so you can share it with colleagues. Okay, thanks very much.
Thanks, Helen.
Bye-bye.